Okay, this will be a quick video on corticosteroids. Corticosteroids mimic a naturally occurring chemical in the body called cortisol. And as you remember from pathophysiology and anatomy and physiology, cortisol is excreted by the adrenal glands. Remember, those sit on top of the kidney, and cortisol has many different effects within the body. Controls serum glucose, regulates metabolism, and reduces inflammation. That is the therapeutic effect that we give a corticosteroid for, namely methylprednisolone. We want it to reduce inflammation. What patients do we want to reduce inflammation in? Basically, 99% of the time, it's going to be respiratory emergencies. You'll see right here COPD exacerbation, asthma, anaphylaxis, spinal cord injuries. I'll talk about it in a second. But as far as your respiratory emergencies right there, what you'll notice the commonality is they have a bronchoconstriction factor, and they're going to be presenting to you in the same way in as far as their signs. You're going to have wheezing, whether it be inspiratory or expiratory, and you can have rhonchi and you can have rales. Because remember, when you get into an extreme case of this, or even a moderate case of these medical emergencies, there's an inflammatory component to that. And remember, part of the inflammation process is edema. So inflammation, and this isn't immediate, but eventually inflammation leads to edema. And now, as you can imagine, patients who are having respiratory distress, edema can be very harmful to them, especially as that medical emergency progresses and gets longer and longer and drawn out. It really affects their way to compensate and maintain any kind of homeostasis. So if we can knock out the inflammation, we're going to do that. As far as spinal cord injuries, you may or may not find this in protocols, but in some EMS services, if there's a suspected spinal cord injury, you're going to be giving Solumedrol, obviously, to prevent any further inflammation of that spinal cord and any insult to that spinal cord. It's that simple. Now, how does it work? Once again, it mimics cortisol. What does cortisol do? It reduces inflammation. It is potentially harmful to the patient if given to the wrong patient. Number one, it suppresses the immune system. So if patients are immunocompromised already, think about your chemotherapy patients, patients who are on immunosuppressive drugs, possibly AIDS patients, things like that. It could be potentially harmful. So you need to weigh the risks and benefits of giving this medication in that specific respiratory emergency. There is conflicting research with pulmonary edema. So if you have a patient with pulmonary edema due to a volume overload or CHF, this is potentially harmful to the patient to give Solumedrol to. It's not indicated pre-hospital. We have better treatments to deal with that, and we've talked about those nitrates, diuretics, CPAP, positive pressure, and even some longer acting opiates like morphine can be helpful to that. So if you are dealing with a volume overloaded patient or a CHF exacerbation with pulmonary edema, do not give Solumedrol. You'll see right there, Solumedrol comes in that really cool vial that you get to push down, and the stopper, remember, kind of comes down here, and then your fluid mixes with the powder, and then you need to reconstitute that, then you draw it up. Adult dose is a straight 125 milligrams. Pediatric is weight-based at 1 to 2 milligrams per kilogram IV. And what's the big thing that you notice here? The onset is 1 to 2 hours. This is something that's going to help a patient's prognosis long term. It's not going to get you through a hypoxic emergent episode in the next 10 to 20 minutes. This is going to help the patient from negatively progressing once you deliver him or her to the emergency department. So that's all I have for corticosteroids. If you have any questions, once again, make sure you submit them through the Blackboard link or bring them to class. Thanks a lot.